This lecture will talk about the care of patients with obstructive disorders of the lower respiratory system. This one is specifically about asthma. There is a genetic tendency to develop asthma. What this means is it is not directly inherited, but the tendency to develop asthma is inherited. So if one or both of your parents has asthma, you can inherit the tendency. You will not automatically have asthma. And the most common predisposing factor is the genetic tendency to be allergic. Once again, you don't inherit specific allergies, you inherit the tendency to be allergic to something. Um, Another etiologic thing is viral upper respiratory infections, and they can contribute to the diagnosis of asthma, and they can also contribute to exacerbations of asthma. One of the viral upper respiratory infections in this category is RSV in infants. RSV stands for respiratory syncytial virus, and uh, most kids before the age of 2 have had RSV. It's just like a really, really bad cold for most kids. But for some kids, especially infants and premature babies in particular, get a really bad case of RSV that can lead to croup or pneumonia. And in those children, there seems to be a higher incidence of asthma. Now, it's a kind of a chicken and egg thing. Are they Do they have a greater tendency to get this bad version of RSV because they have the tendency to have asthma? Or do they have this bad version of RSV and then they're more likely to get asthma because of that? No one really knows, but they are related. Other things that are related are exposure to smoke, pollution, early use of antibiotics, lots of different things linked to asthma, but there really aren't a lot of causative connections there. The incidence of asthma in the US is on the rise. It's more prevalent in African Americans than in white Americans. And people die from asthma. I don't think asthma gets as much attention as it should because it can be a very serious disease. Deaths are more common in lower socioeconomic status groups, possibly due to poor access to care, maybe poor adherence to treatment because it costs too much. Some of these inhalers are outrageously expensive. Of the people who get asthma, about 50% of them develop it in childhood. But with careful monitoring and treatment, asthma can be controlled and the symptoms can be managed so that people lead relatively normal lives. The pathophysiology of asthma includes chronic inflammation and edema in the airway mucosa. So if you look at this diagram, you will see a normal lung with a normal little amount of mucus, and then an asthmatic lung with excess mucus and secretions and a tight muscle. Triggers of asthma cause the release of inflammatory substances such as histamines and leukotrienes, and the bronchospasm is caused by hyperresponsive or hyperreactive airways, which react to the release of these inflammatory substances. In fact, people will often call asthma RAD, reactive airway disease, because that's basically what it is. You've got airways that react to these substances. So the bronchospasm causes really narrowed airways and air trapping uh, beyond the airways. And so you've got obstruction and you can't get the air in to where it needs to get for gas exchange. Acute symptoms are intermittent and generally reversible. However, asthma can cause permanent changes for some people. You get some remodeling of your airways, and that can lead to a progressive loss of lung function. Asthma can occur by itself, but it may also complicate chronic bronchitis and emphysema. is another diagram of what is called here an asthma attack. You can also call it an asthma exacerbation or an asthma flare. And it shows how the air goes in, the air goes out, and then you have the little alveoli there, and then an even bigger, or actually smaller, but it's a bigger picture of a small area, shows you the airway with the normal smooth muscle, the bloodway, a very large lumen, and a mucosal lining. And then next to it, an obstructed airway. So you've got the smooth muscle, which contracts. The blood vessels are infiltrated by the immune cells, which are releasing all of these substances that cause the inflammation and swelling. Therefore, the lumen inside the airway has a decreased diameter, and there's all sorts of excess mucus. So you've got a decreased diameter and excess mucus, which really plugs up and obstructs your airways. This is yet one more picture of a normal lung versus a lung that is having active asthma. So you've got the bronchospasm up there in red. You see the secretions there that are also blocking the airway. And then in the small cutout, there's edema of the bronchial mucosa and very thick mucus. And you'll notice the little deflated alveoli beyond the obstructions, and so no gas exchange is happening in those airways. Sometimes people will say they don't know what triggers an asthma attack, it just happens. But most of the time, you can trace asthma exacerbations back to a trigger. And most often, you will find that exposure to allergens or irritants of some kind are that trigger. The most common predisposing factors, as I said earlier, is the genetic tendency to be allergic. And it doesn't matter what your allergy is. So as you can see from this little picture, it can be foods, it can be pet dander, it can be pollen. The bottom little guy is a dust mite there. That's very, very common. Molds, just all kinds of things. Anything you can be allergic to can cause an asthma exacerbation. Another trigger is a viral infection. For whatever reason, viral infections tend to give you airway edema and mucosa in your airway mucosa, and that can trigger an asthma attack because remember, asthma is reactive airway disease, and so your airways react to the inflammatory tissues from a viral infection just like they do to an allergy. Postnasal drip, same thing. Postnasal drip can irritate your respiratory mucosa and cause an allergic trigger. Exercise, not exactly sure why, but exercise-induced asthma is also a thing, and I would imagine it has something to do with the chemicals that occur during exercise. It may have to do with differences in airflow. I honestly don't know why. I'm sure someone knows. I just don't know at the moment. But exercise-induced asthma is a thing. Also, cold-induced asthma is a thing. And so if your airways are exposed to very cold air, you can get bronchospasm. And so if you think about people who exercise in the cold, for instance, kids who are out in the fall and winter playing soccer, or people who are skiing, snow skiing, those kinds of things. So exercise asthma, induced asthma and cold induced asthma can combine in those situations and make those kids pretty miserable, or adults, I suppose, pretty miserable. Emotional upset and stress can be a trigger to allergy. Certain medications can be an allergy trigger. Aspirin, ASA, acetylsalicylic acid, is the abbreviation for aspirin. That can trigger asthma, and also certain beta blockers, which are non-beta selective, can cause or can be asthma triggers. Gastroesophageal reflux, if you've got gastric juices coming up and irritating the mucosal lining of your respiratory system that can also lead to an asthma trigger. So lots of different things going on here that can trigger an asthma flare. So the big takeaway here is that the disease itself can't be prevented, but exposure to triggers can be, and it can prevent acute exacerbations. You can't prevent every acute exacerbation because, you've got things like viral diseases and stress and different things like that, but other things, other exposures can be prevented. Um, asthma and allergies and chemicals and anything like that, um, controlling gastroesophageal reflux, that can prevent acute exacerbations. Interestingly enough, we have found that there are possible protective factors for the development of asthma in children. This is really interesting. Older siblings in the house. So if you have other kids, maybe they're bringing home more upper respiratory diseases and you develop more antibodies younger in childhood. Dogs in the house from birth, which is kind of counterintuitive, but you never know. Early exposure to daycare, same thing as older siblings in the house. You're building more antibodies to more things earlier. And being in a rural environment, I suspect, is kind of like having dogs in the house from birth. You are exposed to more dust, more animal dander, and perhaps building more antibodies from birth. So, as a society, we have gone to wanting everything to be clean, 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 and our kids not exposed to any dirt or germs. Asthma is on the rise in the US, so maybe there's a correlation here. Maybe everything's a little too clean, and if the kids were just around a little more dirt, a little more animal dander, and had some early exposure and a chance to build more antibodies earlier in life, there wouldn't be as much asthma. Not saying let your kids eat dirt, just saying there's a connection there, and the research bears it out. Control of childhood asthma may prevent serious asthma as an adult, so it's real important to teach people how to control their child's asthma and to involve the kids in that control early so that they understand the need for it and will take their medication and take the precautions they need to take. Avoidance of smoking goes without saying, and it's not just the person smoking, but all smoking. Any kind of secondhand smoke exposure should always be avoided. And I bolded this last statement because it is so true and so important. To prevent acute attacks, you must identify and avoid triggers. And that is the most important thing you can teach your patients and their families. So as I mentioned, asthma flares, attacks, asthma exacerbations this is what it's called when you get symptoms all of a sudden. Usually people go along and they're fine, and then all of a sudden, boom, they have symptoms. This sort of a exacerbation can last from a few minutes to a few days, and what you get is you get chest pain, tightness, difficulty breathing, a lot of coughing. You have trouble moving air in and out of lungs because you have turbulent airflow, swollen airways, and thick secretions. After you have an exacerbations, the airways may remain hypersensitive and hyperreactive for many weeks, and so you're more likely to get another flare soon after you've already had one. Symptoms are often worse at night, which is interesting. There will be people who will just wake up in the middle of the night with an asthma attack. What you hear on exam is wheezing, and sometimes you can get audible wheezing. You don't even need a stethoscope to hear them. And the wheezing is from that turbulent airflow and the swollen airways, the thick secretions obstructing those airways. Remember, wheezing is air moving around an obstruction. Now, if you've got somebody who's wheezing and then all of a sudden you have the absence of audible wheezing, that may or may not signal improvement. It might mean they're better, but look at the whole person because it may be an ominous sign. If the person isn't moving enough air to make any sound, then that means the wheezing goes away, and then that could mean you're really in trouble. So on physical exam, what you will see is you will see an increased respiratory rate and increased respiratory effort. You can hear inspiratory and expiratory wheezes, and like I mentioned, maybe audible. You'll have a productive cough with thick sputum, and the sputum will be clear. It will not be green, yellow, whatever, it will be clear. You can also see use of accessory muscles, and this is a signal that somebody is having a severe exacerbation and they need help now. Looking at the complications of asthma, the most severe complication is what we call status asthmaticus, which is bronchospasm that is not controlled. You get an increased respiratory rate trying to compensate for the narrowed airways, so you wind up hyperventilating and you get respiratory alkalosis from blowing off too much CO2. If this goes on long enough, the patient gets really tired and can't compensate anymore. And so then they go into respiratory failure, and the PCO2 will rise from hypoventilation and they will have respiratory acidosis. This can lead, as I mentioned, to respiratory failure and death. So if you think about hyperventilation and an increased pH, because you have too little PCO2. Remember, the PCO2 or CO2 is acid, so too little acid leads to an increased pH and respiratory alkalosis. Then they get tired and they can't breathe that hard or that fast, so they retain the CO2, more acid, lower pH, respiratory acidosis. The diagnosis is often made on symptoms and a physical exam. There are tests that you can do, pulmonary function tests, and one of them is called spirometry. So what they look for is they look for your peak expiratory flow, which is when you blow out hard and fast, how much air are you getting out? Your FEV1, which is your forced expiratory volume in 1 second. So if you take a really deep breath in and blow it out hard and fast, like that, actually, sorry, you can hear me wheeze. They measure how much volume you can force out in 1 second. And with asthma, that is reduced because of the obstruction. The symptoms are usually reversible with a beta agonist such as albuterol. And so what you do is if you get low airflows on a spirometry, you give them 2 puffs of albuterol and you wait 10 or 15 minutes to get that to take effect, and then you retest. You should see an improvement with asthma, and this is called a bronchodilator response. Sometimes if you're testing someone with spirometry who doesn't have active disease, but you want to rule out asthma, you give them what they call a methacholine challenge, which is basically giving somebody methacholine, a beta adrenergic stimulus, and provoking or trying to provoke asthma. And if you give them that and it provokes asthma, a positive methacholine challenge is also diagnostic for asthma. Something else you always want to do in somebody with asthma is allergic skin testing. If you recall, allergies are one of the biggest predisposing factors for asthma, predisposing triggers. And so always try to get people to get allergy tested so they know what they're allergic to and what triggers they can avoid. Along with that, IgE and eosinophil levels can help determine the appropriate treatment, because if you have allergic asthma, then you need to treat the allergies. And this is something people just do not understand, how hand in hand allergies and asthmas are. And if you treat the allergies, the asthma will get much, much better. Asthma is a chronic disease. It's not a one-off and then you're done with it. And so you need to teach people how to evaluate their asthma on a long-term basis. A peak flow meter, which we'll talk about a little bit more in the next slide, is very important to teach people how to use. And also then, as a healthcare provider, look at their FEV1s on an ongoing basis and see, are they getting better? Are they getting worse? Talk about their nighttime awakenings with them. Have them keep track of that and see if they're becoming more frequent. That's something to look at. Frequency of exacerbations. So when you see somebody, how frequently do you feel like you had an asthma attack or an asthma flare? Another way of getting at that is, how frequently are they using their short-acting beta agonist, SABA, short-acting beta agonist, like albuterol. These are also called rescue inhalers. How frequently are they using those? So they may not be aware of um, exposures. They may not be able to tell you how frequently they're doing or they're having exacerbations, but they can probably tell you how many times a day and how many days out of the week they're using their albuterol. A peak flow meter is something that everybody who have asthma should have and should know how to use. The peak flow meter helps to determine the drug dosage needed and how to control the asthma. It also helps to predict the effectiveness of therapy, and it will detect airflow obstruction before it becomes serious and requires hospitalization. Peak flow meters and incentive spirometers are often confused. Incentive spirometers, you inspire in, and that's what moves the ball or the lever on the incentive spirometer. A peak flow meter, you breathe out, you blow out, and that's what moves the needle on the incentive spirometer. They have zones on these, and they're usually marked at when the manufacturer usually marks these. However, you can, on some of them, set the zones yourself. So basically, green zone, you're good. Breathing is fine. You're not coughing. You're not wheezing. Just do what you're doing. Take your long-term control medicines. No problem at all. Yellow zone, caution. Maybe you're feeling a little cough, a little chest tightness, but you can do pretty much what you would normally do. So take your relief medicines when you need to, and if you don't get back to that green zone, then you might want to see somebody. Red zone, danger. If you have any symptoms, asthma is getting worse, if you are coughing a lot, if you're having trouble walking, talking, doing your normal activities of daily living, medicine is not helping, maybe fingers or lips are blue, that's really a problem, call your doctor or 911 now. So using this peak flow meter is a very good habit for people with asthma to get into, and it can really help them be aware that their asthma is getting worse before they even have symptoms. So the goals of medical treatment for asthma are to minimize the irritation and relieve the obstruction that is caused by secretions, edema, and or bronchospasm. And this is done with medications, most notably inhalers, to prevent or control infection and allergy. We've talked about that a lot. You also want to increase their activity tolerance, and so increasing them to exercise is good. and then determining the best combination of drugs that controls the symptoms. Because what you want to be in asthma is you want to be proactive with drugs that control the symptoms as opposed to reactive with drugs to treat the symptoms. So medications used to treat asthma can be used intermittently or continuously. Usually when people start out with asthma, especially if it's exercise induced or you don't necessarily know what your trigger are, you will use a short-acting bronchodilator, SABA, or a rescue inhaler such as albuterol, intermittently to control symptoms. These can also be used prophylactically to control bronchospasm during exercise or before exposure to other triggers. So for instance, if I have asthma and I'm allergic to dust or mold and I'm getting ready to clean my house, should maybe take a couple of puffs of albuterol beforehand to calm my airways down so that the exposure doesn't trigger an asthma attack. If you use a rescue inhaler more than twice a week for symptoms, then they consider starting maintenance meds to prevent symptoms. Because remember, prevention is what's important here. Prevention and control. So quite often they will start out with inhaled corticosteroids because if you think about it, what's going on in the airways is inflammation. What are corticosteroids? They're anti-inflammatory. And so inhaled corticosteroids are used as a long-term control medicine for asthma and usually the first-line drug of choice. They must be used regularly. This is not a rescue inhaler. So if you are having an acute attack, inhaled corticosteroids is not what you reach for. What you reach for is the short-acting bronchodilator, the albuterol. Long-acting beta agonists, and one of those is salmeterol, are usually not used alone, but they are used in combination with inhaled corticosteroids. Two drugs that are combinations of those two things are Advair and Symbicort. These are very popular drugs. Long-term beta agonist is exactly what it says. It's a beta agonist that lasts 12 to 24 hours, depending on the drug. And so what you've got in combination here is the inhaled corticosteroids to prevent the inflammation and the long-acting beta agonist to keep the airways open and prevent the bronchospasm. Really good combination drugs. They are used a lot. Another type of medication that is used for bronchospasm is an anticholinergic. Ipratropium or tiotropium are medications that are used for this, and sometimes you'll see a long-acting beta agonist and an anticholinergic used together. These can be really useful. So as you can see, what happens with asthma treatment is you start with one thing, and then if that doesn't work, you add another thing, and then if that doesn't work, you add another thing. So start with steroids, add a long-acting, and then maybe add an anticholinergic. Another kind of medication that they use is a leukotriene inhibitor. Montelukast or Singulair is an oral medication that people use. If you recall, leukotrienes are one of those inflammatory mediators that come out and cause the inflammation, and so this is to prevent that. Same with mast cell inhibitors. Mast cells are inflammatory mediators, and the drugs keep the mast cells from being released. You must treat the allergies, and so any kind of an antihistamine or sometimes immunotherapy for allergy shots, or now they have sublingual immunotherapy for allergies. Super, super important if your asthma has an allergic trigger. Another thing that they use, and this is kind of a last resort thing, is a drug that I can't pronounce, but its trade name is Xolair, so I'll call it Xolair. Maziliumab or something like that. Anyway, what this is it's a sub-Q injection that works on allergic asthma that has failed all other kinds of treatment. It is outrageously expensive because it's a recombinant DNA thing. And so your IgG levels have to be pretty high, and there's a whole lot of other hoops you have to jump through to use this, but more and more people are using biologics for a whole host of other things these days, and Xolair is an effective biologic asthma, or agent, excuse me, against asthma, made by Genentech, actually, which is a local company. So pretty much everything I talked about in the previous slide was medication for long-term control. Medications for exacerbation are a little different. Inhaled beta agonists, as in an albuterol inhaler, are important, but in a pretty significant exacerbation, inhaled beta agonists in a nebulizer work much better. There are IV corticosteroids or oral corticosteroids that can be used IV in an emergent situation, and then sometimes they'll put them on oral steroids for maintenance. Sub-Q epinephrine is a beta agonist that is used quite often for status asthmaticus in the emergency department. Sometimes you will need supplementary oxygen if you've got a particularly bad exacerbation and they're having trouble getting oxygen in or getting gas exchange going. They will use supplementary oxygen if people's SATs are dropping. When you have IV steroids, as I mentioned, they'll continue oral corticosteroids sometimes, and then those will have to be tapered off depending on how the person's doing. Again, this is one of the things where they follow their peak flows to see how they're doing, and then as their peak flows get better, they'll try to taper off the oral steroids. If you haven't gotten the message already, people must learn to control their asthma at home. They monitor and manage their symptoms, monitoring with that peak flow meter, keeping track of their rescue inhaler use, of their nighttime awakenings, and if they can avoid acute episodes and hospitalizations, if they can manage their triggers, they will avoid acute episodes and hospitalizations. This self-monitoring, as I mentioned, includes not only symptoms, but monitoring their peak flows, just getting in the habit of doing your peak flows every morning after you brush your teeth. Really good method for asthma control. Identifying and avoiding those triggers, treating the allergies, and you got to get tested and know what you're allergic to before you can treat it. Pre-medicating prior to exercise. Have the kids or the adults keep their albuterol inhalers in their basketball bag or soccer bag or whatever. And then also just make sure that they avoid allergen exposure when they can. Irritants like pollution, wood smoke, campfire smoke, wood fireplaces, things like that. Cold air is another trigger, as we talked about, and also certain medications. There are beta blockers that are not cardioselective. Examples of those are propranolol and metoprolol. Boy, hard for me to say. And if you've got somebody who's on one of these drugs and is all of a sudden wheezing, then perhaps they need to be taking something else to control their hypertension. Aspirin, as I mentioned, and also certain NSAIDs can be triggers. And so really look at all of the possible triggers, not just the allergies, not just the upper respiratory infections, but look at the medications they're taking as well. I think by now you've probably gotten the message that a lot of nursing management is patient and family teaching in terms of how to take the meds, which meds are which, what's your rescue inhaler versus which is your long-term inhaler. Smoking cessation, so important, not just for the patient, but also for the family members. And then psychosocial care. Asthma is scary, and having a child with asthma is scary. And so really helping them to understand how to manage the asthma will help a lot with those fears. If you're writing a care plan, some priority diagnoses, impaired gas exchange, because of the bronchospasm, ineffective airway clearance, because of the bronchospasm and the mucus, anxiety, really a big deal if you can't breathe, if you're the person having the exacerbation, really a big deal if it's your kid having the exacerbation. Knowledge deficit, they need to understand about the meds, about control, the triggers, the peak flow meters, and then also risk for infection. Just using some common sense in terms of keeping away from crowds during cold and flu season, getting your flu shots, that sort of thing. I know this sounds like I'm beating a dead horse here, but this is just so important. They need to know what the zones are in their peak flow meters. What's your green zone when the airflow is normal? What's your yellow zone? Maybe when you ought to increase your routine meds or maybe use a rescue med. And what's your red zone when you need to use for sure your rescue medications and get help now? Correct inhaler or nebulizer technique is very important. I know you talked about this in pharmacology, but I tell you, inhalers are not easy to use, and it's very important that they use the correct technique or they might as well not even be using them. And then finally, of course, the importance of controlling triggers and controlling their allergies. This isn't something that you necessarily need to memorize, but I mentioned earlier that treatment of asthma is sort of a step-by-step additive treatment, and that's basically what this is. So mild intermittent asthma is something that they'll use rescue inhalers for. Mild persistent asthma, they might add an inhaled corticosteroids. Moderate persistent, they might add a long-acting or bronchodilator to the long-acting inhaled corticosteroids, and on and on and on. Severe persistent asthma is sort of the final step. It's not responsive to anything that they've done before, and one of those things that they would probably do some IgE testing and consider the use of a drug like Xolair for. So if you're taking care of somebody with asthma, the big thing to look for, of course, is hypoxemia. And one of the very first signs of decreasing oxygenation may be restlessness or confusion. Uh, Again, this is true especially with older adults, and if you've got an older adult with a cognitive impairment, increasing confusion or behavior change and restlessness is always one of the first signs of hypoxemia. You may have somebody who wants to sit upright a lot, and that will allow for better air excursion, chest excursion. And so somebody who is sitting upright to sleep won't lay down flat, sitting on 2 or 3 pillows or sleeping on 2 or 3 pillows. You'll see a respiratory rate increase, and later what you'll see is flaring of the nostrils and retraction of the respiratory muscles as the condition worsens. This means get help now. Cyanosis is a very late sign. Do not wait for that. If you've got somebody who's got nasal flaring, retractions, hypoxemia, of course, you're always monitoring them with a pulse oximeter and you're giving them high flow oxygen. You are monitoring them continuously. This is a situation where you're always going to call your charge nurse. You're going to notify the physician if it's an inpatient situation or send them out to the ER. One thing that's contraindication for that high flow oxygen is if you have somebody who has a history of COPD. The oxygen rate should start with 1 and then go up to 3 liters per nasal cannula until the crisis has been resolved. But again, if you've got somebody with COPD and asthma, this is a very complex situation, and this isn't somebody you want to manage that you're on your own. You need to send them out to the ER.